Okay, so I'm going to talk a very big subject, which is renal tumors in pediatrics. I've sent some MCQs, and I think the first MCQ was what was the most common renal tumor in children. And this showed either mesoblastic nephroma, renal cell carcinoma, nephroblastoma, or obviously the true answer is nephroblastoma. So the incidence in North America and Europe, it's about 1 in 10,000. America gets anywhere between 650 and 850 cases. Asia is less, almost half. And 80 to 90% is nephroblastoma, which is Wilms tumor. In Saudi Arabia, the best statistics I can find was 45 cases per year. This was 2017. The median age is 38 months. The girls, for some reason, present 6 months later on average. And 90% of new tumors present before the age of 7 years. Renal tumors come in different types. Of course, we said nephroblastoma is 90%. You have congenital mesoblastic nephroma, clear cell sarcoma, and rhabdoid tumor of the kidney, which were part of the Wilms tumor study group initially, and then when it was noticed that it was different characteristics, they split it and separated. Nephrogenic rusts and renal cell carcinoma. We'll get into details of each one of these. Nephroblastoma is commonly known as Wilms tumor. It's the most common renal tumor. 90 to 97% are sporadic. The rest are associated with genetic diseases and present earlier in age and have a higher incidence of bilateral. This gentleman here is Dr. Max Wilm, a German surgeon who first described Wilms tumor, and he died in the First World War after treating a patient with diphtheria at the age of 50. And in Germany, W is spelled V, so it's actually Wilms tumor, but I'm not going to pronounce it as it will be Wilms tumor for the rest of the presentation. Some of the diseases that's very common with nephroblastoma is Weger, which is Wilms tumors, and aniridia, genitourinary abnormalities, and mental retardation. This is associated with the loss of Wilms tumor gene 1 in PAX6 on the 11th chromosome P13. Beckett-Wiedemann syndrome or overgrowth syndromes are common to have Wilms tumor. Beckett-Wiedemann syndrome, they have exophthalmos, macroglossia, hypertrophy. Perelman syndrome is another overgrowth disorder. Dennis-Drash syndrome also present with Wilms tumor, have a higher incidence. And there are a lot of syndromes there. Wilms tumor can be renal or extrarenal. They can present in the uterus, the colon, suprarenal gland, and chest wall. Usually they're unilateral, but 5% of those can be multifocal. This is in more detail showing the risks. So high risk greater than 20% are usually in WT1 deletions, including Weger. 85% of these are unilateral. WT1 mutations, including Dennis-Drash, familial Wilms tumor, Perelman syndrome, and Fanconi's anemia. Moderate risk 5 to 20%. Fraser syndrome, Beckett-Wiedemann, and Beckett-Wiedemann, up to 60% of children affected with this syndrome can develop Wilms tumor. Lower risk is isolated hemihypertrophy, Bloom syndrome, Lieframoni syndrome, and trisomy 18, trisomy 13. The embryology, the oncogenesis happens by this simplified thinking. Uncommitted cells will give rise to teratomas. Committed cells will give you blastomas. So metanephric blastema will change into nephrogenic cysts and nephroblastomosis, and this will raise or give rise to nephroblastoma. Wilms tumor arises from pluripotental embryonic renal precursor cells. These cells usually disappear by 4 to 6 weeks before birth. It's unknown why they don't disappear and why it transforms. It's a very big subject, and there's a lot of detail in it if somebody's interested in reading more. Usually, classically, they're triphasic, so they have epithelial, blastemal, and stromal elements. The epithelial is the tubules. Blastemal, if it's present in high phase, are purely monophasic blastemal, usually they're present with higher advanced disease. The genetics and molecular biology is extremely complex. It is very detailed, and I think it's a bit too much for surgeons to go into, but it happens that there are genes that control the normal renal development. The WT1 on chromosome 11, P13, 20% of Wilms tumor will present with that, and WT2 chromosome 11, P15, and biological factors, loss of heterogeneity at 1P and 16Q. These are the three most important things to understand as a surgeon. This slide here of histology shows the blastemal, the epithelial, the stromal, and the tubules. These cells will try to create fetal kind of nephrons that then develop into nephroblastoma. Second MCQ we had was the most common presentation of renal tumor was a hematuria, weight loss, and asymptomatic abdominal masses, and hypertension. These were the four choices. And the most common presentation is asymptomatic abdominal mass. I hope we all get that kind of presentation. So that's the most common presentation. Usually they present with asymptomatic palpable mass felt by a parent, and more commonly a caretaker. So like a tree growing, won't notice it, but somebody comes and visits them and says, you know, your child has a protruding tummy. And a medical doctor on the usual examinations at the age of 2 and before school at 5. 20% present with hematuria or hypertension, flank or fever or flank pain. Now, if they present with pain and hypotension, you have to be very concerned about rupture. And this can happen with a fall. So even if you get a trauma, you have to keep in mind that some sort of healthcare and access are very important. The study comparing GPs in the UK that commonly see children and versus pediatricians in Germany that are specialists and they get first access to the child. It showed that in the UK they present with larger tumors and later stage, and that makes a difference of 3% in event-free survival, overall survival. In Wilms tumor, this is a big difference, a big percentage, because we're talking about almost over 90% of Wilms tumor will be effectively having 90% EFS or OS. That's a big difference. Syndromes with high risk, the ones I showed on the table before, need surveillance every 4 months with ultrasound until the age of 7 years. Sorry. The workup, first thing and the easiest thing to do is ultrasound. And I always include the ultrasound Doppler to look at the vessels, make sure there isn't a thrombus there. CT is the most common investigating done. The current trend in Europe is MRI, but still the COG, the Children's Oncology Group still prefer a CT scan. And the reason is MRI, you need to sedate children, and that can come with its own risks. So you need to define the origin, extent, and also metastasis. Also confirm presence of a functioning contralateral kidney. Chest X-ray was historically used for the chest, but now we use CT scan, and there's challenges because previously whatever you see on a chest X-ray would show up later on a CT scan, and you'd say, well, is this a true met or not? And we'll get into details about pulmonary metastases. Age 1 to 5 years, 5 years old. This is the most common age. The usual blood work, coagulation profile is important, and acquired von Willebrand disease in 8%. And even after correction of all bleeding factors, you can get bleeding with acquired von Willebrand disease, and this surgical bleeding will stop after vessel control. I just because I don't want to miss it later on when I talk about surgery. Now this is a CT scan with the left Wilms tumor. This is a typical appearance. On the MRI, this is here on the right. As you see, you can still see a rim of renal tissue around it. And here it's important to look at the IVC in the renal vein. This is called the claw sign. I had a better picture that showed this, but basically you'll see parts of the kidney, the normal kidney, going into it like claws into the mass. And this is a very typical appearance of a Wilms. If you notice here on the side, you might think it's penetrating. Actually, they don't penetrate into the anterior abdominal wall. They're not as invasive as other tumors. Now, staging, you have two schools. You have the Children Oncology Group, which is American-based or North American-based, and CIOP, which is European. I won't talk about the UK staging or the UK treatment because that is now part of the CIOP. COG, the most important thing is that primary surgery is their approach. If the tumor is resectable, they'll go ahead, and biopsy if not. So their staging is a pre-treatment staging, while CIOP, their approach is preoperative chemotherapy, then surgery. So their staging is pathological. And both has its pros and cons, but the best thing is whatever your team, the oncologist and the institute is comfortable with, this is the approach and the staging you should take. So there used to be a National Wilms Tumor Study Group. It started in the USA in 1969 from 3 different groups, which were already studying Wilms tumor. So they wanted to collaborate to gather a significant number of patients so they can have statistical power. They did 5 clinical trials. The last one, NWTS 5, is still, they're still gathering late effects. Since 2001, it's a children's oncology group that a lot of you are probably aware of. Now in COG Stage 1 and COG and CIOP, Stage 1 and 2 is probably the same, as well as 4 and 5. Big differences on 3. So in Stage 1, the tumor is limited to the kidney, has been completely resected, no rupture or biopsy prior to removal, and no penetration of the renal capsule or involvement of the renal sinus vessel. Now, to have a correct Stage 1 after resection, you have to have good representation of lymph nodes. If you don't take enough lymph nodes and you call the patient to Stage 1, they're actually not Stage 1, they're Stage 2 or 3. So Stage 2 is tumor extending beyond the capsule of kidney, but it's completely resected with no evidence of tumor at or beyond the margins of resection. There is penetration of the renal capsule or there is invasion of the renal sinus vessels. Stage 3 is gross or microscopic residual, remains post-operatively, including inoperable tumor, positive surgical margin, regional lymph node metastasis, and this is important that you have to have a representation of lymph nodes to correctly diagnose or stage the patient, a positive peritoneal biopsy, transected tumor thrombus, and tumor thrombus, if it's free-floating and easily resectable, it's a Stage 2. If it's adherent and stuck to the vessel wall, it's a Stage 3. And if the tumor was ruptured or biopsied transperitoneally prior to removal, that's a Stage 3. Previously, fine needle aspiration was accepted and not really placed as Stage 3, and true cut biopsies placed as Stage 3, but now all biopsies are part of Stage 3. Stage 4, you have hematogenous metastasis or lymph node metastasis outside the abdomen. Examples are the most common is lung, liver, bone, and brain. Stage 5 is bilateral renal involvement at diagnosis, and each side is given a local staging. So you have the disease stage is Stage 5, but locally it could be a Stage 2 and a Stage 1, or a Stage 3 and a Stage 2. So it has to be documented pre-surgery and post-surgery. COG Histology, 90% Wilms tumor favorable histology. So in COG, it's favorable or unfavorable. And favorable histology usually consists of the classical blastostroma, epithelial, and tubular elements. Tumors can contain various portions. So sometimes you can have no blastema, but stromal and epithelial more, or you can have pure blastema, which is unfavorable. Triphasic tumors are more characteristic lesions, but biphasic and monophasic lesions can occur. They do not predict outcomes except that blastemal part. Abnormal mucinous or squamous epithelium can be found. Muscles, skeletal muscle, cartilage, osteoid fat, calcifications can be found in Wilms tumor. Unfavorable histology is tumors that have focal or diffuse anaplasia, and these are defined by these multipolar polypoid mitotic figures, large giant nuclei with diameter at least 3 times of adjacent cells, hyperchromasia, and you can see these here. So this is a slide of anaplasia. Focal anaplasia is defined as the presence of few distinct or localized regions of anaplasia within a primate tumor. The rest of the tumor shows no nuclear atypia, so that's focal anaplasia. Diffuse anaplasia must have at least one of the following four criteria. You have anaplastic cells outside the kidney, in a lymph node, for example, presence of anaplasia in a random kidney biopsy, anaplasia in more than one region of the kidney. So these are multiple rests that developed into nephroblastoma, and each of one of them has anaplasia, or anaplasia in one region with extreme nuclear polymorphism in other sites. And this is very important. Diffuse anaplasia has a poor prognosis. COP, on the other hand, their stage 1 is almost the same. So this is after treatment. The tumor is limited to blood soup outside the contact of the kidney and is clearly resected. The tumor may be bulging the pelvic system and dipping in the tumor, but not infiltrating. The renal sinus are not involved, and there's necrotic tumor. Because it's been treated. Stage 2, tumor infiltrates the renal sinus or invades blood and lymphatic vessels outside the renal parenchyma, but is completely resected and blocked. This tumor can infiltrate adjacent organs, which is very uncommon, or the vena cava, but is completely resected. Percutaneous cutting needle biopsy is allowed in COG. Stage 3, this is incomplete excision of the tumor, which extends beyond resection margins. So you have gross positive margins or microscopic tumor that remains postoperatively. Any abdominal lymph nodes are involved. Tumor is ruptured before or during surgery, irrespective of other criteria for staging. So if it's a stage 1, but it's ruptured or spilled, so this is a stage 3. Tumor has penetrated the peritoneal surface. Tumor implants are found on the peritoneal surface. Tumor thrombi are present at resection margins or of vessels or ureter and transected or removed piecemeal by surgeon. Has been surgically biopsied, wedge or open biopsy prior to preoperative chemo surgery. Stage 4 is metastasis, either lung, liver, bone, and brain, or lymph nodes outside the abdominal pelvic region. Stage 5, bilateral renal tumors at diagnosis. So almost stage 1, 4, and 5 are the same. 2 and 3 are a bit different in COG. COG post-chemo risk stratification, 3 groups. Low risk is completely necrotic nephroblastoma or cystic partially differentiated nephroblastoma. Intermediate risk is regressive epithelial stromal, mixed or focal anaplastic nephroblastoma. And high risk is blastemo diffuse anaplastic nephroblastoma. And in COG, the histology diffuse anaplasia is almost the same. Anaplastic cells outside the kidney or in random kidney biopsy in more than one region of the kidney or one region with extreme nuclear polymorphism other side. So they define it in a percentage of 2 years. So here I'm going to go into the breakdown. And I remember as a fellow, I found the tumor board would be talking about all these different studies, and I wouldn't understand what they're talking about. So I thought I'll give you a small speech one. So NTWS 1 was performed to determine the effect of surgical technique on the results of treatment. They found that post-op radiation needed in less than 2 years old, and after complete resection. They also introduced combination chemotherapy here. In 2, it studied Prognosis a bit more. Chemotherapy was decreased to 6 months instead of a year and a half. It was adriamycin, a new chemotherapy agent, was utilized. NTWS 3 reduced the treatment for low-risk patients and found better chemo for how the radiation was not treated, was not needed for favorable histology because radiation has a lot of side effects. Cyclophosphamide is not very well tolerated by children, and they found the favorable histology wasn't needed. Also, they decreased the radiation and found that higher doses that were given before no longer needed. The 4th study was to evaluate the efficacy, toxicity, and cost of administration of different regimens. And you find generally as these studies go, the amount of chemotherapy that is given as in courses are decreased. Every course in Wilms tumor is 3 weeks. So when they say we're giving 4 courses of therapy, that's 12 weeks. So you have to say, okay, 12 weeks, and then we're going to reassess and see if you need to operate. So it's important to understand what the oncologists are doing so we can give a good surgical management. So they found that pulse therapy is better than divided courses. 27 weeks was effective 18 months. So that's a huge drop from 18 months to 6 months to 27 weeks. They also looked at surgical aspects. Local tumor recurrence was significantly increased if there is a tumor, regardless of spill or biopsy. And this led to upstaging of stage 2 to 3. The fifth study identified biological prognostic factors, loss of rigidity 1P and 16P. This showed poorer prognosis in stage 1 and 2 favorable histology. So they thought stage 1 and 2 favorable histology, they're better, but they found that these patients weren't doing as well as they expected. And they found this biological factor to be important. And this LOH 1P and 16Q has become very important in subsequent treatments. And we'll get into the detail of that, inshallah. So the management of full tumor as per NWTS year 2001 was as follows. Stage 1, favorable and unfavorable, got 18 weeks of citromycin and vincristine. Stage 2F, favorable histology, the same thing. 3 and 4 stage favorable histology got 24 weeks plus radiation of the tumor bed and involved sites if there was pulmonary or liver mets. And unfavorable histology from 2 to 4 got 24 weeks of treatment. Now CIOP, same thing. CIOP started a bit later than the National Women's Tumor Study group in 71, and both groups utilized each other's data. So you'll find a lot of things have been it's almost the same protocol now. So preoperative radiotherapy significantly prevents tumor rupture and uses favorable stage distribution. And this is probably the most important thing in CIOP, that they found that giving chemotherapy or treatment before surgery shrunk the tumor, made surgery easier, and decreased intraoperative rupture. But the COG trials showed that as the surgeons are more experienced and better at it, the tumor rupture risks are decreased, much decreased than the first 2 or 3 studies. They found also actinomycin D did not improve disease-free survival or overall survival. CIOP-2 was completed in 1974, and showed they confirmed that preoperative radiotherapy was helpful. And that's why still CIOP will do preoperative radio and chemotherapy. Post-operative chemotherapy was 6 months, as good as 50 months. So even in CIOP,
Sir Ahmad, we cannot hear you.
So they stopped giving radiotherapy and only gave chemotherapy. CIOP-6 in 1980, stage 1, treated with only two medications, was effective for 14 weeks, as for 38 weeks in terms of event-free and overall survival rates. So you see, as similar as the North Americans, they found that they didn't need as many medications as they expected. And they found in stage 2, patients with negative lymph nodes were assigned to receive no radiation therapy had a higher recurrence rate. So that to them was a bit different than North America. CIOP-9 is an 87, stage 1, 2, 3, 8 preoperative treatments, not distribution compared to 4 weeks. So now they started giving the preoperative treatment 4 weeks instead of 8 weeks. And patients with negative lymph nodes, the rate of relapse was reduced by treatment with epirubicin without radiation therapy. In 93, they reduced the post-operative chemotherapy for an intermediate risk and anaplastic risk to 4 doses of vincristine and 1 dose of actinomycin. And that was not less effective than the previous treatment. So CIOP localized its 4 treatments of DAM and VCR and vincristine and metastatic. This is in addition to the pre-op chemotherapy. Now, both those management protocols are defunct. And this is the CIOP protocol, localized. This is still ongoing, I think. I'll go to the next slide. So the management approach, and when I talk about management here, I'm going to talk about the COG protocol mostly. Tumor board is essential. You have to have a pediatric oncologist who's comfortable with women's tumor, a radiologist who's very comfortable and good at treating and diagnosing women's tumor, and biopsying if needed, surgeon and the pathologist. So these are the 4 core people that have to be in the tumor board. And each decision in the management should be done with 4 people present. Surgery is essential. Chemotherapy, radiation, flank versus whole body. Metastatic locations also sometimes need radiation. Surgery can result in increased treatment or upstaging, or can also result in understaging patients. This is the chemotherapy regimens for COG currently. So EE4A is vincristine and actinomycin. Ironically, you go a letter lower, DD4A, and it's a more complex chemotherapy regimen. Vincristine, actinomycin, possible radiation therapy. Regimen I is vincristine, actinomycin, doxorubicin, cyclophosphamide is added, and regimen M is vincristine, actinomycin, doxorubicin, and added to it is etoposide completely. H1. Same regimen, but they add carboplatinum and H2. And unfortunately, I have to go through the chemotherapy regimens in detail for you to understand, because I think as surgeons, we should understand it. It really affects what we do, and what we do affects what they're going to give. So this is a bit busy, but this is a risk stratification and treatment assignment. So now currently, all COG patients are, now generally, if you look here, there's very low, standard, higher, and bilateral. So off the bat, anaplastic is going to be 0.533, bilateral is 0.53, the standard is 0.532, okay? Under the age of 2, less than 550 grams, stage 1, very low risk. A lot of stage 1 and 2 here, it's written none, but they actually get the old regimen DD4A or EE4A. And I'll get a bit more into it. This is a bit confusing, but just follow with me. So with COG, what they've done is a central review. So all slides, all imaging go to the COG central review area, which is called AREN0321. They classify the patients and review everything and make sure that the pathology and the staging is correct. So you have favorable histology. If they're very low risk or standard risk, they're getting higher risk or standard risk, they're getting 533. Low risk is on the 03B2, which is basically falling back to the previous regimen, which is DD4A and EE4A. Anaplastic is 0321 and bilateral is 034. Okay. Now 0532, stage 1 and 2, 1 less than 2 years, 550 grams. This is very low risk. Nephrectomy and observation. They've noticed that even if they relapse, they are given the EE4A, the DD4A regimen, and their overall survival and disease-free survival rates are as good as any stage 1. Okay. Now, stage 1 and 2 with no loss of heterogeneity 1P and 16Q, they're low risk. They're off protocol, but they are followed by the central committee, and they get the minimum chemotherapy, EE4A. Stage 1 and 2 with loss of heterogeneity 1P and 16Q, and this is what NWTS 5 showed, they get a higher treatment, which is DD4A and no radiotherapy. Stage 3, no loss of heterogeneity, so they have a better biological factor. They get the standard risk DD4A with radiotherapy because the lymph nodes are positive. Stage 3 with a higher risk biological marker, positive or high risk, and switch to 0533. So this is 0533 and it's very busy. So patients, I'll start with this one here, transferring from 532, the previous slide. This is stage 3 favorable histology, but after the tumors were resected, they were treating as if they had no LOH, but they discovered that they had LOH, so he had to not upstage them, but give them more treatment. So stage 4 favorable histology, Wilms tumor will get the 3 drug chemotherapy agents, DD4A, for 2 cycles, and after 6 weeks we evaluate. Now stage 4 is metastatic, right? So this is metastatic. Stage 4 with pulmonary lesions that respond within 6 weeks, okay, with no loss of heterogeneity, they complete the DD4A, okay? So they go continue this way. They don't get pulmonary radiotherapy. So these patients had positive lesions on the CT scan in the chest, and after 6 weeks, they're resolved. They don't see them anymore. So here, you don't need to give pulmonary, you continue the regimen DD4A without radiotherapy. You also got local radiation for stage 3 patients, and to non-lung metastases, they get radiation. If they're stage 3 or 4 with loss of regeneracy, both loss of regeneracy or stage 4 pulmonary lesions that did not resolve, or with metastases other than lungs or in combination with lungs, they change into regimen M. They get whole lung radiotherapy for stage 4 pulmonary lesions, the slow responders. They get also, if they had no NOH, no LOH, and if they had LOH, regardless of pulmonary nodule response. And stage 3, they get radiation and also radiation to non-lung metastases. Now, 0321 is high-risk tumors, anaplasia, and focal anaplasia stage 1 to 3 or diffuse anaplasia 1 are treated with DD4A. This is the same regimen as 15 years ago. Stage 4 focal anaplasia, stage 2 to 3 diffuse anaplasia, and stage 4 diffuse anaplasia without measurable disease are treated for 30 weeks with regimen UH1 with radiation therapy. Patients with stage 4 diffuse anaplasia with measurable disease are treated to 1 to 2 cycles with the window therapy, irinotecan, vincristine, to evaluate a tumor response and determine that it should be added to UH1 and becomes UH2. Okay, so UH1 and UH2 are anaplasia, high risk, and they're part of 0321. Last is 0534. Bilateral wounds tumor received neoadjuvant therapy with 3-drug chemotherapy of regimen DD4A to shrink the tumors before surgery. Tumors are arising in solitary kidney or patients under the age of 1 year with unilateral wounds who are at increased risk of metachronous tumor. That means they're genetic, have genetic syndromes. They're treated with regimen EE4A if their stages 1 to 2, but DD4A stage 3 to 4. So 2 medications or 3 medications. According to the stage. After 6 weeks, 2 cycle, or at the latest 12 weeks, which is 4 cycles, they get the surgery. It's not allowed to give more than 12 weeks of chemotherapy. So after 12 weeks, you have to operate. And post-operative chemotherapy and radiation is determined by the histological findings. Okay, so that is the medical treatment, which is a big chunk of difficulty in understanding the management of Horseshoe tumor. Now we'll get into biopsying, spills, and surgical management. Biopsy is the main step in management of all renal tumors. True or false? It's actually false. It's not true. So tumor biopsy, pre-nephrectomy tumor biopsies are contraindicated in COG. Because there is a high risk of recurrence in patients who had tumor spills or ruptures, irrespective of cause or extent of swelling. So transperitoneal, if you have to do a biopsy, better to do it through the flank retroperitoneally rather than because there is increased local recurrence, and thus you're going to give more adjuvant therapy. Tumor biopsy prior to nephrectomy is considered a local spill. That upstages patients to stage 3. And doxorubicin, which is very bad cumulative doses to the heart. There is about 4% chance of patients with wound tumors who have doxorubicin to get cardiac failure down the road, and they get 10 centigrade flank radiation, which is also has its own complications. So it's only performed when a tumor is deemed unresectable. Open or multiple core biopsies are recommended, better for obtaining the biological samples. Needle biopsy cannot distinguish between a tumor arrest, and it cannot diagnose diffuse anaplasia. So needle biopsy is no longer used. Surgical management, either primary or adjuvant. Now, local stage must be defined in addition to the disease stage. So could be stage 4, but you have to define locally if it's stage 1, 2, 3. It's contraindicated at first approach if it's a stage 5. So all bilateral wounds tumors will get neoadjuvant chemotherapy. If you have a tumor thrombus reaching above the hepatic veins, tumor in solitary kidney, or tumor invading other organs except adrenal and diaphragm, and patients with pulmonary compromise. These are the 5 contraindications for primary surgical management. The best surgical approach for a renal tumor, that's one of the MCQs. Transperitoneal simple nephrectomy is something that should not be done in Wilms tumor. It's radical nephrectomy. So laparoscopic nephrectomy is not part of COG. There are some reports of doing laparoscopic nephrectomy in Wilms tumor. This is still under study. It has been done in renal cell carcinoma in adults, but right now with COG, it is not a recommended approach. Retroperitoneal nephrectomy is associated with poor lymph node status, and really you won't be able to see the peritoneum or see if there's any peritoneal implants, and there is a higher risk of rupture with retroperitoneal nephrectomy, so it's not recommended in COG. Transperitoneal radical nephrectomy is what is used for Wilms tumor. So the surgical guidelines for stage 1 to 4 is safe resection of tumor. You have, is it kid versus kidney, and save the child, okay? You cannot compromise the child's life to take the tumor out. You have to get accurate staging, avoid complications that may upstage the tumor, especially spillage. Accurate documentation, very important to say, to document everything, and we'll go into detail a bit about it. It's transperitoneal transverse incision, absolutely the biggest incision you can make. Inspect and document all surfaces, so peritoneum especially is commonly missed. Radical nephrectomy, so when you look at the bed of the tumor after you resect it, you should see only muscle and all the fat is gone. Primary ligation should not be done if technically difficult, or it's a large tumor or there's excess lymph nodes. It's not recommended at all in COGS now, so you have to do it if it's safe. The reason is because of there's been reports of tying off the SMA, the aorta, the femur mesenteric artery, lots of complications trying to delve into the vessels without mobilizing the tumor first. My approach is to mobilize the tumor superior laterally, superior medially, inferior laterally, define where the ureter is, and it becomes much easier once you mobilize a lot of the tumor. If the adrenal gland is abutting the tumor, it should be resected. Lymph node dissection, hilar, para-aortic, and paracaval. On the right, you should search for lymph nodes in this area. So even if it's at the root of the inferior mesenteric artery or between in front of the IVC, you have to get at least 5 lymph nodes for COG and 7 for SIOP. On the left side, it's easier to get lymph nodes on the left side for some reason. So sampling of perinephric lymph nodes is not mandatory. That's completely false. It's mandatory. Surgical principles. So you don't need to inspect the contralateral kidney, only if there is a suspicious lesion on the preoperative imaging, and you have to open gratis fascia, deliver the kidney, inspect both sides, biopsy the suspicious lesion if need be. And this is what I was saying, lymph node dissection is mandatory. Do not biopsy in vivo. That means you see the tumor that you're trying to get, do not open it, do not bisect it after you remove it. The titanium clips is only for residual or suspicious area and margins of dissection. So only four clips should not be used for vascular control. That is something that I've changed my practice. Biopsy any suspicious lesions and ID them with a clip, and the best thing is to put a suture and put the clip on top of the suture. And the reason is post-operatively, if you need to image the patient, the clips can cause a lot of shadowing, and it make it very hard to read the CT scans. No extensive resection. You do not need to take the spleen out or the pancreas or the colon. Maybe the tip of the pancreas if necessary, but you don't need to resect any of these lesions. Diaphragm and muscle is allowed. Partial nephrectomy and unilateral Wilms with a normal contralateral kidney is not indicated, except if it's syndromitic, and usually they need neoadjuvant and nephron sparing. Send the specimen fresh. Make sure it's received by a pathologist, and never leave it on a weekend, because I've had tumor left over the week of miscommunication. Make sure that the pathologist receive this. And in your dictation, also assign local regional state. Any peritoneal spillage will determine the extent of radiation therapy. Now, the peritoneum is considered soiled if there has been a biopsy, either pre-op or intraoperatively, of a tumor that is removed at initial surgery. if there's been a preoperative rupture, if there's an intraoperative tumor spill, if the tumor has been removed in more than one piece. And this follows also with the tumor intercaval extension. I'll mention that also in another slide. Local spills are defined to those limited to the renal fossa. Any soiling mandates a stage 3 therapy and radiation. Separate, if you find a tumor or nodules on the surface or surface, these are a preoperative tumor rupture, not quite metastasis. And inherent tumors that remove no tumor spill, but cutting across the tumor during removal of lymph nodes, for example, that makes it upstage. Transecting the renal vein or ureter at the site of tumor extension also. Bloody peritoneal fluid might be considered a sign of rupture. A large amount of blood is unusual. Usually you'll find a capsular disruption, and it has to be documented. If there is a hematoma as well, you assume that tumor cells will spread with the blood, and these are classified as preoperative rupture. The tumor may penetrate the renal capsule and overlying peritoneum. The rhonioplastic tissue surface in free communication peritoneal cavity can be found. If this is already there before surgery, that means it's a preoperative rupture. You can sample the peritoneal fluid for cytology, but the problem is there's a lot of false positives, and if malignant cells are found, they send them to the center pathology, so they can and if it is positive malignant cells, preoperative rupture. IVC thrombus, it's very common for it's not common, but 20 can extend into the renal vein or the proximal IVC, and they can be removed and blocked. So intraoperative management of a tumor thrombus requires proximal and vascular and distal control. So if the tumor thrombus is intrahepatic IVC, you have to control above it. If it's retrohepatic IVC, you have to control above that. Some reports of intrapericardial caval control by opening the chest. I think that's a bit too much. If that is needed to be done, then preoperative neoadjuvant chemotherapy is probably better to be given in that kind of scenario. So for renal vein thrombosis, you should milk it out, and if it's freely easily floating, you just control the vein, create a venotomy, and it just flips out. So you don't have to mobilize a lot, and that's a stage 2. Sometimes the thrombus adheres to the vein, leading to piecemeal removal, and that will be a stage 3. Extension to the hepatic veins or atrium should be given neoadjuvant. Cardiac bypass only if after neoadjuvant chemotherapy is given and the lesions persist. There has been no evidence in improved survival or with cardiac bypass versus neoadjuvant than operating or decreasing the IVC thrombus, but the complications with cardiac bypass is more. So this is a MRI with caval IVC thrombus. It can be quite extensive. You can see them going right up to the atrium. Ureteric extension. Extension of Wundt's tumor in the ureter is a rare event. Can be difficult to detect with preoperative imaging, around 2%. Usually, if you have gross hematuria or past, that will give you a cystoscopy with retrograde ureterogram to aid in the preoperative evaluation. It's best to milk it, resect it with clear margins. Now we come to special cases of Wundt's tumor, horseshoe kidney, single function kidney. You have a Wundt's tumor and a horseshoe kidney. They're usually treated as having a unilateral tumor, not bilateral. The blood supply to horseshoe kidneys are quite valuable, as in the location of the tumors, should be delineated prior to their operation. The side of the kidney containing the tumor, including the isthmus, and the same side ureter has to be resected. Notes are sampled for stage. Children with a single kidney or they have a kidney and the other one is non-functioning should be managed using neoadjuvant chemotherapy or preoperative chemotherapy and renal sparing approach. Intra-abdominal mets, any suspicious site, as we mentioned, should be biopsied or resected if possible at exploration. If there is residual intra-abdominal disease at weak chemotherapy, it should be resected only if feasible. Complete resection is not feasible, then residual disease should be reassessed for feasibility of resection at the chemotherapy. chemotherapy. So after the 18 or 28 weeks, depending on the regimen. Pulmonary metastasis is strongly recommended that if there's any doubt of the nature of pulmonary nodules, that they should be biopsied, as a lot of them, a third, can be not metastatic tumors. Stage 3 and 4 usually will receive the same chemotherapy for the first 6 weeks. These are the ones with the fast or slow responders. Patients with residual pulmonary lesions at this time will receive whole lung radiation. Focal stage 1 and 2, it's critical to find the nature of small pulmonary lesions at diagnosis, because this will upstage chemotherapy. So if there's week 6 and there's still lesions, and you doubt the lesion, the nature of the lesion, you can biopsy them prior to committing them to whole lung radiation and intensive chemotherapy. So these are the slow responders, or are they shadows or are they actual lesions? So even if all disease is surgically resected, they'll still receive intensified therapy. And most of these mets are peripheral, superficial, can be removed thoracoscopically. Some larger lesions, you need to do a thoracotomy to resect them. So, as we already mentioned, 15% of children with pulmonary radiation will develop breast cancer. This is very important. So if you're going to have them avoid pulmonary radiation, that's best. They metastasize also to the bone, and surgical resection is not rarely recommended, and only if it will result in removal of all disease. So it's treated primarily with radiation therapy. Brain mets, surgical resection metastases, it should be considered before the initiation of chemotherapy if complete resection is feasible. Bilateral tumors, they can synchronize, so at the same time, or move on, and then later on they present. Synchronous about 6% of tumors in the Western literature. Before the procedures, and patients were on dialysis, renal transfer, very poor out. So CIOP started first with preoperative chemo, including bilateral wounds, and the North Americans. And this is an example, right kidney wounds, and you have to have 2/3 of one kidney, or a third each side to remain postoperatively and they're functioning. You have to individualize each patient and look at the tumor volume. If really large tumors and then renal transplant is a must, but hopefully most can be resected. Some have advocated radiation to save as much kidney as possible. And I always stress here, these kind of cases require 2 consultants. So you can utilize a second consultant to assist very difficult patients. This is a very busy slide, I'm sorry, but it's very easy. The children that are less than 6 months of age, CIOP has a different protocol because you can't give them chemotherapy. They have good prognosis, and mostly surgically is indicated for small or medium-sized tumors that can be resected. They're stage 1. They don't need further therapy than nephrectomy. Mesoblastic nephroma usually occurs in young babies, and a lot of diagnostic dilemmas are between a Wilms tumor, a cystic nephroblastoma versus a mesoblastic nephroma. Mesoblastic nephroma are benign tumors, and no therapy is needed after nephrectomy. Sometimes you need to do you might need to do reduction of tumor size. These babies don't tolerate chemotherapy very well, and vincristine is given alone before the nephrectomy. If they're large stage 2 or 3, these can also be given chemotherapy, but actinomycin D causes a lot of side effects for babies, so the doses are decreased. And usually for stage 2 postoperative treatment is according to similar to stage 1, 18 weeks. There are dose reduction protocols. Abdominal radiation is poorly tolerated, and they have very bad complications. Prognosis, usually excellent, more than 85%, which is stage 1 and 2 familial histology wounds tumor with negative loss of heterogeneity. It's clear cell sarcoma of the kidney and rhabdoid tumor. I'll talk about in a couple more slides here. 75 to 84% are almost the rest of some anaplastic histologies, or almost all anaplastic histologies, or very late stage clear cell sarcoma or malignant rhabdoid tumors. So it's still more than 70% is very good prognosis. Most of the children can achieve more than 75% event-free survival. End-stage renal failure and unilateral bilateral mentioned before, that's very usually better. In the 50,260 patients in COG, only around 1% developed end-stage renal failure. This is higher with unilateral wounds with anomaly, and of course, higher than in wounds tumor, 14%. Follow-up every 3 months times 8, so you're looking at 2 years follow-up, and then another 2 years, and then another year. So 5 years follow-up, every 3 months, every 6 months, and then once a year. They have to have CBC, urinalysis, make sure their kidneys are functioning, a CT scan every 3 months, and then after they generally will get a CT of the chest and abdomen every 3 months for the first year or two, and then you can switch to chest X-ray. Echo, if they had doxorubicin, they have to have it yearly. If relapse occurs, it's higher in familial types or anaplastic histology. The leading locations of relapse are lung, then the flank, and then the liver. The mortality rate of patients with recurrent failure histology is 25 to 40%, but recently this has improved to 60%. So they get the primary treatment, then they have relapse, and then they have treatment, and they still have 60% chance of good outcome. There's three risk groups. The standard risk relapsed wound tumor. Surgery is given when feasible. Radiation and chemotherapy, and this is alternating courses of vincristine, cyclophosphamide, etoposide, and cyclophosphamide. Patients with high risk and very high risk, they get more chemotherapy, surgery, and radiation if needed, and stem cell transplant is recommended for these patients. In CIOP, they have group AA, BB, and CC. And group AA, they only give vincristine, dactinomycin, no radiotherapy. And because the first-line treatment was higher, group B is intensive reinduction regimens given with these chemotherapy agents, followed by high-dose methylene and stem cell rescue. Group CC is they give camptothines and novel compounds that are defined by CR. I'll mention just a clear cell sarcoma and malignant rhabdoid tumors of the kidney. They were grouped initially, as I mentioned, National Women's Tumor Group studies, and they were part of unfavorable histology. Now they're distinct entities, and they have different biological appearance and biological behavior, and they respond to different therapies. So clear cell sarcoma is a malignant tumor, and it has unusual tendency of bony metastases. So they have large unifocal unilateral tumors. This is the appearance, very mucoid, tan, and they have foci of necrosis, and they can create cysts. A clear cell sarcoma can invade the surrounding kidney, unlike Crohn's tumor. And they recently found that some translocations and deletions have been defined. The cell of origin of this tumor is not known. They can also metastasize to the brain. They're still doing clinical trials to find out what treatments to be given. 30% of relapses occur more than 2 years diagnosed. Rhabdoid is more aggressive. It's very lethal renal tumor. They're encapsulated and invasive with characteristic involvement of very high renal. Till recently, I've not found a single case of a rhabdoid tumor and brain met that has been successfully treated. And if you come across one of these, it's probably better not to do a nephrectomy. This is their under histology. They have a prominent large or owl eye appearance. They look like skeletal muscles, but they lack the striations, and it suggests a neuroectodermal origin. The brain tumor that they have is medulloblastoma, deletion 22q11 to 12 has been described in renal and extrarenal tumors. Nephrogenic rest, because we're running out of, I'll give you about 15 minutes for treatment, for discussion. These are persistent of metanephric tissue in the kidney after 36 weeks of gestation. Precursor from tumors, but because they found 30 to 40% of kidneys removed for Wound's tumor. In NWTS 4, nearly half of the unilateral, almost all the synchronous Wound's tumor were associated with nephrogenic blasts. Imaging in the children less than 5 years old, the wounds is spherical, exophytic, or larger than 1.75 centimeters. Nephrogenic blasts tend to be part of the capsule. They're not spherical. They can be defined differently than Wilms with a good radiologist. They're also subclassified in perilobar and interlobal types. Interlobal rests reflect earlier disturbances as nephrogenesis. Perilobar, on the other hand, are usually multiple and occur far more commonly in the newborn population. Diffuse nephrogenic blast is termed nephroblastomatosis. They can involute, undergo hyperplastic overgrowth, or progress to focal neoplastic induction. These have been studied in the latest COG trials, and they show a substantial degree of pathogenic heterogeneity for Wound's tumor. Renal cell carcinoma, I just will mention it because it can occur in children, especially in genetic von Hippel-Lindau syndrome is the one-known syndrome. They arise from cells from the proximal convoluted tubule. The 5-year survival rate is 65 to 90%. Their chemo radios are resistant. The only case I came across was in the native kidney after a renal transplant on a child that was on immunosuppressives, and it was on the same side of the transplanted kidney. It was a very difficult resection. And that's the end of the presentation there.
Dr. Abdulwahab, thank you so much. You summarized the topic in very good and easy way, mashallah. We will see if there is any question, and we will try to answer them all. Okay, the first question, what to do in the cases of non-responsive to chemotherapy, and in a way that the tumor increases on size, and if there is any new developed lung metastasis, and what is the causes of the non-response, what to do? Should we go for rebiopsy, or we should upgrade the chemotherapy, or you will go for surgical resection?
Okay, so anytime something like that happens, a tumor board should be instituted. The pathology has to be revised. I would recommend to perform the biopsies again. It's very unusual to have non-response. It's possible these are anaplastic and they have to have upgraded chemotherapy because this is very unusual. If it's already been biopsied, it's a Wound's tumor, but it was given EE4A, for example, and they missed an anaplasia somewhere, then maybe that patient has to be rebiopsied and found out. But usually, if they don't have Mets and the tumor has been the tumor is resectable, then go ahead and resect it initially. It's probably better not to provide resection first go than even if the patient has Mets. If locally the tumor looks like it can be resected, even if there's lung metastasis, you can still go ahead for the resection. NWTS, I saw this. So National Women's Tumor Group, I mentioned that it's a systematic classification. It's basically a group that studies women's tumor, and this is now the Children's Oncology Group. That not just that, they have a study now called the B3 study, and this is every tumor, and now in conjunction with SIOP, they've created this umbrella group. It's called the umbrella, and anybody that sends the pathology and radiology to them, they'll give you an answer within a week with the staging and if they concur with the pathology. And up to now, they have 6,000 cases of Wound's tumor. So now we're having a global Wound's tumor study group. And I think that's great because every single type of patient that can occur with Wound's tumor will have tailored treatment for him. Okay.
Okay, we have another question. Does the vascular clamping during an open nephron sparing surgery is associated with a higher incidence of renal complication?
Well, with as much as possible, I try not to clamp the major vessel. So if you're doing a nephron sparing, a patient has had chemotherapy, shrunk the tumor. Now, let's say it's in the lower pole. When you're dissecting, you dissect the branches of that pole. So you control the vessels of the area that you want to resect. You don't want to create any ischemia to the kidney that you're leaving behind. So as much as possible, don't clamp the main vessel. Does that make sense?
Yeah.
Decrease ischemia as much as possible. Also, I forgot to mention, when you're tying the ureter, always use an absorbable suture. Don't use a non-absorbable suture, because that's associated with high risk of stones. You don't have to take the ureter right down to the bladder, okay? As low as you can safely get it, that's enough. And always milk, and make sure after you cut to look inside the ureter so there's no thrombus. Of course, it's probably better to know beforehand, but I do that step every single time I do a women's tumor section. Okay, SIOP, I think both now use CT scan, but there is a lot of controversy, which is what is pulmonary met. So SIOP says if it's less than, I think, 3.5 millimeters, we're talking about millimeters, it's not a met. With COG, it's less 1 centimeter, but the modality now that you do is CT scan for the chest. Chest X-ray is only for follow-up. That's what I do. Venous thrombosis, any rule thrombolytic agent, preoperative and postoperative? No, they're actually tumor thrombus, not a venous thrombus. So it's tumor that has invaded the renal vessel at the hilum, the hilar vessel, and it's growing, but it's fungating within the tumor. It's like a pipe, and you've poured not cement, but you've poured some yellow in, or ajina, some dough inside. So what happens is it respects the wall, the endothelium of the vein, and it just keeps going into the IVC. And then in the IVC, because of the flow of the blood going from the lower limbs up to the liver, it starts growing like roots of a tree into the retrohepatic IVC, and eventually can reach to the heart. And there has been 1 or 2 cases reported of cardiac failure, where it actually went and occluded caused cardiac outlet obstruction. That's very, very rare. Now, distilled water in case of tumor spill. I try not to irrigate. So my technique and what is written in COGS to protect the rest of the valve is you use big sponges to isolate the rest of the valve from your surgical site. And I only remove that to get the ureter, which is almost at the end of the case. Once you spill it, there's nothing you can do. If it spills, the best you can do is just get all the chunks out, irrigate locally very gently, because you don't want all these tumor cells to go to the rest of the abdomen. Hopefully, if you do that and you document that, it just gets radiation to the flank. You really don't want to give the patient abdominal radiation, whole abdomen radiation, because this will happen if you irrigate profusely. So very important to make sure that your blood loss is minimum, absolutely minimum. So even if you're used to using clips, what you can do with some vessels is you clip the vessel with a titanium clip, because sometimes it's hard to tie there if it's very tight. So you clip and then cut, you go back to that clip and suture ligate below it and remove the clip. Best thing for a tumor spill, if it's surgically iatrogenic, try avoiding getting an iatrogenic spill. Very gentle, do not push on the tumor, don't press on it. I really try not to handle the tumor as much as possible till I actually need to get behind it. And it has to be one surgeon only that handles the tumor. Do not let the assistant handle, so it's only 1 or 2. So peritoneal lavage, I try as much as possible not to irrigate after a womb's tumor. Just a little bit to get the blood out. But the last things I remove are my packs. Which
vessel you will ligate the first, the artery or the vein?
Whichever is easier. Sometimes the books show you 1 artery and 1 vein, but really I've seen as much as 4 arteries and 2 veins. So whichever is easier. I don't think that by the time the inflow of the artery into the kidney is going to make the kidney so large that it's going to be hard to manage. Theoretically, as you're managing or resecting a tumor, these microscopic tumor cells are going to go into the bloodstream. But we know that this Wilms tumor is a systemic disease. It's not just a local disease, because we're giving systemic chemotherapy to get every single tumor cell out there. So I personally don't have a preference. I just do whatever is easier. Do we have to keep the patient postoperative on Foley catheter to prevent renal reflux? No, I usually keep the Foley catheter just to reassure myself for the urine output post-op. Usually these patients are in ICU, and I say I want to make sure they're getting enough hydration. So definitely more than 1 cc per kg per hour is the minimum urine output, and you should stress it and continue stressing that what's the urine output, what's the urine output. Don't remove the Foley catheter till you're happy. Usually second day or third day. I mentioned that don't use the clips because a lot of clips, you see an X-ray after my second or third Wilms tumor, all you see is just clips everywhere, titanium clips. And when I want to do a CT scan later on to see for follow-up, there is a lot of marking and streaking from these clips. So now the recommendation from COG, not from me now, is don't use a lot of titanium clips. So I've changed my practice to suture ligate and avoid using hemostatic clips. If you have clips that are radiolucent, like the hemoclip, you can use those. And why not? Why not dissect it dissect it. So when you remove it, these tumors can be cystic. So the weight of the tumor, especially in stage 1, less than 550 grams, and also for the pathologist, you want to give it to pathology. Pathology will photograph it as gross, and then they cut it and dissect it. I'm not a trained pathologist. I'm not trained to do Wilms tumor grossing, and I don't find at all helpful after surgery to open my tumors. It's not important. My job is to take the tumor out. Make sure that it's safe to take the tumor out, resect the tumor as safely as possible, get as much lymph nodes as I'm supposed to get, and put the clips there, document everything, and out. My job is not a pathologist. I give the tumor intact, fresh, for the pathologist to bisect. So if you bisect, you can get part, even if you change your gloves or anything, there's no point in bisecting it. It's not important for management of the disease. And secondly, you change whatever findings the pathologist will be looking for, okay?
Okay, mashallah, Dr. Ahmed, you answered all the questions, and it was very enjoyable talk, mashallah. If you have any other question, you can ask Dr. Ahmed on Twitter. You can post the question on his Twitter account. It's showed on the slide, and also you can post it on our account on PD Surgery Review. Dr. Ahmed, thank you so much. We are very happy to have you in our course, and inshallah, we'll see you soon, inshallah.
I appreciate it a lot, and thank you very much. There are 2 references to use here. There's an APSA handbook of renal tumors, very helpful. The APSA webpage has a very good resource for surgeons, and there's some seminars of pediatrics have a good review of Wilms tumor from a medical perspective. If you're more interested in reading about the therapy of chemo and radiation, okay? Thank you very much.
Thank you so much, Dr. Ahmed.